I'll show you.
Well, good morning, everyone. So, thanks Deepak for having me here from Bangalore. So, I see all the future young intensivists. So, very good morning and glad to see the whole crowd. So, today I'll be talking on update on ACS. I think this is something where there's a lot of changes that has been happening, and I think cardiology, as you would imagine, there's tremendous changes that happen literally every year. So, you all need to be abreast about what is really happening in the world of cardiology. So I think the topics that I would cover is the key changes to the practice guidelines, ACS, because that is something you all need to know. And there are a lot of newer insights into pathogenesis and pathophysiology. Some of it I think we are expected to know. And newer risk factors, because we know about all the conventional risk factors. I won't be talking about conventional risk factors, newer risk factors that are identified. Biomarkers, I think that is something very important. And the role of imaging, because this is really seeing a lot of phenomenal change, and obviously the treatment, because there are that many number of studies in cardiology, you really need to ascertain what is it that you want to crystallize from all those studies. And little bit about the stents, because I'm sure that also we are expected to know, and lipids and take home message. So if you look at the background, I think the ACS in 2010, I think 1.1 million patients were having ACS. This is a US data, out of which 74% were MI and STEMI was 29 to 47%. So that's the sort of a US data. And if you look at the predominant risk factors, I think these three constituted predominant risk factors in that population. And in all these patients, I think high sensitivity cardiac troponin was found to be very useful because it had a very good pickup rate as opposed to most other biomarkers. So that is in sort of a background for you. So when you look at the new guidelines that came out, so these are endorsed by these American Heart Association, European Cardiology Society and ACCF in 2017. So the key changes is what I think we all need to sort of remember. So for STEMI, ST elevation MI, so the time frame for fibrinolytic therapy is 120 minutes. So it is class 1 evidence, which is a strong recommendation, and level of evidence is A. So which means it has a good level of evidence. And the suggestion is that within 3 to 24 hours, I think patient has to be transferred to a hospital where there is modalities for definitive therapy, so which is angioplasty. So that is class 2A or level of. So even though you may have done thrombolysis in a hospital within 120 minutes, but you cannot continue to keep the patient there. They have to be transferred to a place where some definitive procedure can be done later on. And hypothermia still is there in recommendation. I know there is evidence moving away from hypothermia to more of normothermia, but in witnessed VFVT arrest, normothermia at least we can agree upon, and mild hypothermia, class 1 level of evidence is B still. I think that will change subsequently, I would think, with the newer evidence that is evolving. And even after cardiac arrest, I think there was a lot of contention whether we should wait to assess neurological status. But now the recommendations say that immediate angiography and angioplasty has to be considered if it is a witnessed VFVT arrest, and that also class 1 level of evidence B. So because there is this sort of a nebulous area where you would think that whether his neurological status is okay because he's had a VFVT, but if it's a witnessed VFVT where good CPR is happened, I think there's no real sort of a reason for us to wait. So you need to probably subject him to angiogram and angioplasty at some stage. So I think this is another important change because you have seen at least some 3 to 4 landmark studies on balloon pump, so which we will talk about what those studies are. So there is a de-emphasis on balloon pump. Although I may be articulating this, but this seldom happens in most of our hospitals because most of our ACS do get balloon pump. So the intra-aortic balloon pump, the recommendation is de-emphasized from class 1 to class 2. So it is a weaker recommendation now, and level of evidence is also B. So when it's again the new recommendation, if you look at these antiplatelets, I think this is something which we have to little pay attention because we still use aspirin and clopidogrel, but now the recommendation, because all the landmark studies recently have shown the newer antiplatelets P2Y1 inhibitor, prasugrel and ticagrelor, is found to be superior to clopidogrel. So in fact the new recommendations say aspirin with prasugrel or ticagrelor is preferred over clopidogrel. So that is class 1 level of evidence A. So which is a strong recommendation and a good evidence. So even in my hospital, I don't see this in a very convincing way. So maybe over time, I think this practice will change. And there is a concept of triple therapy. So triple therapy where we add two platelets, aspirin with P2Y12 inhibitor along with anticoagulants. So that is triple therapy. So there is a reasonable body of evidence for triple therapy in high risk patients, but the recommendation is we should not continue this for more than 12 months. So we have to use it for less amount of time, whatever we determine as normal. So, but it should not be more than 1 year because the risk of bleeding is very high. And for that also there is class 1, which is a strong recommendation, but level of evidence is sort of little lower. And if they are on anticoagulation with vitamin K, I think INR has to be maintained at 2 to 2.5, which is class 2B recommendation. So this is in high risk patients where there are certain group of patients who would need this triple therapy, where anticoagulation is added to dual antiplatelets. So when it comes to non-ST elevation MI, unstable angina, again as you see the newer recommendation is the newer antiplatelets, prasugrel and ticagrelor are preferred over clopidogrel. It's class 1, level of evidence is B. And when you are using clopidogrel, the loading dose has to be 600 mg as soon as possible, that is class 1, level of evidence is B. And as I said, dual antiplatelet therapy if you give, I think it has to be given for at least 12 months. And then maybe have to be determined whether it has to be continued or then you come down to one platelet. And if you are giving P2Y12 inhibitor, I think the recommendation is should not be given for more than 12 months because we have been reiterating that more than 1 year, I think the risk of bleeding tends to increase. So slowly you may have to curtail the usage of triple sort of a therapy or continuing dual antiplatelets of P2Y1 inhibitor for more than 12 months. So post angioplasty, if your patient has undergone angioplasty, the recommendation is give aspirin with ticagrelor, that is class 2A, level of evidence is B. So those are sort of a new practice guidelines. So we will elaborate as to what is the evidence that prevails behind those new guidelines. So when it comes to pathophysiology, there is a whole room of research that has been happening and there is a lot of changes in pathophysiology. If you look at this NEJM article which came in 2013, just pay little attention because the core concept of pathophysiology lies in this figure. So this is the atheromatous plaque as you see, and this plaque is well covered. So whoever has atheromatous plaque, it is well covered by the fibrin cap. And there are basically the whole cardiac event or ACS is attributed to inflammatory process, so which are mediated by T cells. So these T cells produce interferon gamma, and this interferon gamma basically weakens this collagen cap or the fibrin cap because the fibrin cap maintains the integrity of the atheromatous plaque. So if the integrity is lost because of the inflammatory process you see, the interferon gamma will actually inhibit the fibroblast to produce this collagen. So there is reduced collagen formation. So there is reduced support network for this whole fibrin cap, which means the atheromatous plaque will crack and will give way. So there will be a plaque rupture because of collagen breakdown that happens because of these inflammatory cells. That is one pathogenesis. And the second is there is a lot of foamy macrophages. So as you see, this is the foamy macrophages, and they bind to lymphocyte by CD40 ligand, and they produce something called matrix metalloproteinosis, which break again the collagen. So the core element of pathogenesis lies on the breakdown of the collagen cap or the fibrin cap, and that breakdown will lead to cracks in the atheromatous plaque, and that's when your thrombus formation happens. So that is the key pathogenetic mechanism, and it is attributed to your inflammatory process mediated by the T cells. Okay, so that is the sort of understanding we have got at this point of time as to why the thrombus happens in acute coronary syndrome. So the Italian guy, I think in 2013, they came out with a pathogenetic mechanisms. So it is divided into 3 arms. So there is something called obstructive atherosclerosis and systemic inflammation. So obstructive atherosclerosis is again, as I mentioned, so there is an inflammatory process which is mediated by infectious agent and by autoantigens, and that leads to plaque erosion and fissure. So basically that fibrin cap will give way, there is a plaque rupture, and that leads to white thrombus formation. And there is another entity called, there are 3 pillars to having any MI. So the other one is obstructive atherosclerosis without systemic inflammation, which can be due to a lot of local mechanical stress or emotional stress or any of the stress factors that we attribute ACS to, and that itself can lead to the plaque rupture. So it can be the inflammation mediated by the infective agents or any other toxins, or emotional stress which can lead to the plaque rupture, or there is something called non-obstructive atherosclerosis mainly mediated by vasospasms, where there is vasoconstrictor stimuli, there will be a proximal or distal vasospasm that sets in, which again leads to plaque erosion or plaque fissure, and then it leads to the thrombus formation. So I'll just show you that video just to make things easy to understand. I think this video shows a good way to understand how the plaque formation happens and how the plaque rupture happens. So that's the healthy coronary artery, as you see. So that's the LDL cholesterol. Oh, sorry. I think there is volume to it. I don't know where to find volume here. Try to keep the mic. I see the volume, but I'm not getting it here. There is a background voice to this.
Volume is off, I think.
See, your volume is here.
Don't escape it. Recording will go. Volume is off. You can, like, volume wire is not connected.
Sure, I think it's okay. So as you see, there are inflammatory cells. That's the plaque formation there happening. So I think what we have understood is the lipid core, which remains at the core of the plaque, is what really determines the stability of the plaque. I think that there is a study by Madder et al. Who has determined the size of this lipid core really determines the plaque stability and the plaque rupture. And as you saw in the previous figure, the fibrous cap, I think that maintains the integrity of this atheromatous plaque. And for any reason, any inflammation that you have, emotional stress or infectious or proximal distal spasm, I think it will give way. So as you see, the weakening of fibrous cap and enlargement. So the weakening of the fibrous cap and enlargement of that lipid core, I think these two form the main pillars of any ACS that sets in. So that's where you see the crack. Once the atheromatous plaque gives crack, I think that's where the thrombus formation happens. So you see the thrombus formation. Right, so we'll just move. So when you look again pictorially here, so this is how the atheromatous plaque. So as you see, these are nodular calcification that gets formed within the atheromatous plaque, and there is a lot of inflammatory cells which causes of this nodular opacification or the calcification protrudes into the lumen of the vessel, and there is a narrowing of the vessel, and the atheromatous plaque gives way. And there is this lipid core, which is big necrotic area sitting in the center, and there is a new angiogenesis that is happening. So these are all the sort of key elements that lead to the atheromatous plaque rupture. So this is another video which again you can see how the thrombus formation happens. So as you see, this is the blood flowing and this atheromatous plaque, it gives way, and that's when all the blood platelets and other cells get accumulated there, and then you have a thrombus formation. You see a big thrombus. So and that leads to MI. Okay, so I think that, so if you understood that key pathogenesis, I think that is the current understanding of our pathogenesis. So when you look at the new risk factors, because I'm only talking about the new risk factors, so there is a big genetic preponderance to acute coronary syndrome. So there is something called microscopic RNA, microscopic ribonucleic acid, which regulates the target gene expression, and they have identified 3 micro ribonucleic acids, which are 126, 197 and 233. So these are the genetic components of the micro ribonucleic acid, which is known to indicate a patient to be at a risk for MI. And when someone has this expression of these genes, I think it is shown that these are the patients who are at a high risk of reduced salvageability of the myocardium and are at a high risk for the reperfusion injury, and they are at a high risk for the remodeling of the LV. So these are the 3 sort of a genetic traits that they have looked into, which lead to a bad outcome in an MI. So basically it boils down to genetics. So there is genetic preponderance as to which are the patients who may not do well after an acute coronary syndrome when they have expression of these genes. And there is a research going on in trying to identify proteins called antagomias, which sort of work against this expression of these genes. So this is happening in research. I think you can be aware of this. So genetic is one of the important risk factors, and if you want to remember the genes, those are the genes. And oral contraceptives. So this was a landmark article which came in 2012 by the Danish group. So anyone who is on oral contraceptives, so this was a study done in 1.6 million people who were on oral contraceptives. So they found there was increased in risk in mortality and increase in the risk of MI. So in patients who are on oral contraceptives. And this was another study by the Danish group where patients who are on NSAIDs, so they looked at patients, 100,000 patients who are alive 30 days after MI, and if they had taken NSAIDs, so within 1 year the risk of MI increases to 30%, which means NSAIDs have a direct bearing on increasing the risk for myocardial infarction. And if you have taken NSAIDs after MI, within 5 years the risk of death due to MI increases to 41%. So NSAIDs are also an important risk factors for acute myocardial infarction in someone who has history of ischemic heart disease. And this is another important area. So this came in 2013, psoriasis. Because anyone who has psoriasis, I think it is found mild psoriasis, there is 30% increase in the MI risk, and severe psoriasis, there is 70% increase in the MI risk and 40% increase in the cardiovascular mortality. So genetic, then oral contraceptives, NSAIDs, psoriasis. I think these are some of the areas where research has happened, where they constitute as important risk factors for ACS. And what about post-ACS VT-VF? Because we know after acute coronary syndrome, patients have a tendency to develop VT-VF. So we have to understand this as a very important. If someone develops VT-VF, it is an indication of reperfusion injury. As you see, the hazard ratio of mortality goes up to 7 times, 7.4 times, if someone develops reperfusion injury after ACS and develop VT-VF. But what is interesting to note for all of us here is, because there is a overzealous enthusiasm to discharge the patient very fast. So if you discharge the patient within 2 days or after 2 days, if they develop VT-VF, the hazard ratio of mortality goes up to 15, which means our zeal and enthusiasm to discharge the patient early, and if they develop reperfusion and VT-VF at home, the risk of mortality goes up to 15 times. So it questions the safety of early discharge. So early discharge is considered as possible risk factors. So the genetic, psoriasis, NSAIDs, contraceptives and early discharge is now being considered as risk factors for death due to ACS. And another important risk factor that we have sort of evolved in the recent times, we're all aware of the TIMI score. TIMI score is around 10 years old, but they have come out with a modified TIMI score. So TIMI score is stratifies risk score in patients with STEMI. And the TIMI score, the archaical TIMI score, typically consisted of findings at initial presentation, but it did not take any events that happened during the hospital stay. So now they have come out with something called dynamic TIMI score. So that is the latest in the risk assessment or risk stratification, which takes 6 events after the patient develops MI. So anyone who develops a stroke after an MI, or anyone who develops reinfarction after MI, or anyone who develops failure or arrhythmias, or anyone who develops GI bleed or acute kidney injury. So these are the new 6 factors that has been added on into the TIMI called as dynamic TIMI score. So our old TIMI score still remains, but this is something called dynamic TIMI score, which is a new score which is incorporated in the present guidelines to stratify the risk of patients if they develop any of these complications after an acute MI. So this is the scoring, and so this is the modified TIMI score is now what has been incorporated in the risk stratification, and it gets around 29 points. Very simple, anyone who develops stroke, GI bleed, acute kidney injury, reinfarction, failure or arrhythmias come under the category of dynamic TIMI score, and that's the scoring you can look at. So we'll move to the biomarkers. I think all of us here, so we will not dwell into conventional biomarkers which are very clear, CPKMB, troponin, but we look at the caveats of troponin, because cardiac troponin is still the gold standard. So, but the problem with cardiac troponin is it can go up in ischemic, it can go up in non-ischemic conditions also, and there can be non-analytical issues also, because there are a lot of conditions where cardiac troponin can go up in non-ischemic, and in non-ischemic it's divided into cardiac and non-cardiac. So in cardiac, anyone who has myocarditis, pericarditis, or who's had a cardiac surgery, viral cardiomyopathy, they all can lead to increase in the cardiac troponin. And troponin leak can happen in sepsis, can happen in acute kidney injury, can happen in stroke, and can happen with certain drugs. So you have to exercise that sort of discretion when you are interpreting cardiac troponin. So what we have understood now is, if someone has an ST elevation MI, we have moved to high sensitivity cardiac troponin. So someone having ST elevation MI with high sensitivity cardiac troponin elevated or change in the high sensitivity cardiac troponin in 1 hour pretty much confirms that patient probably has MI. So there are studies to see the corroboration. So this was a study by US group. So if you look at the CKMB 3 to 5 fold increase, it was found to correlate with 50 to 100 times increase of cardiac troponin, and that had a bearing on 1 year mortality. And this was another study which came from US, which looked at 2,544 patients with symptomatic ACS, where if you had normal high sensitivity cardiac troponin with a normal ECG, the risk for major adverse cardiac events was less than 1%, which means if you have normal ECG and normal high sensitivity cardiac troponin, it's extremely unlikely that patient has had a cardiac problem. So this was another study which looked at 1957 patients who had angina, who had symptoms in less than 6 hours. Here if you have negative cardiac troponin and they looked at copeptin less than 14 picograms, and with normal ECG, it pretty much rules out acute MI. So it is extremely important for the August audience here to understand when we absolutely rule out that patient is not having cardiac outment. So do high sensitivity cardiac troponin and you can do ECG. If these two are normal and the change and the serial high sensitivity cardiac troponin in 1 hour, I think pretty much we could rule out. So these are some of the conventional biomarkers which we are currently using. High sensitivity, I'm sure most of you are using, we are using it with ECG. But there are newer novel markers. So this is one marker, so which is pregnancy associated plasma protein A. So this is a novel biomarker which they have identified. It is a zinc metalloproteinases. Basically this is an atheromatous plaque within the blood vessels. Basically this pregnancy associated plasma protein A cleaves IGF-4, insulin growth factor 4 from the insulin growth factor 1 within the atheromatous plaque. And this sort of destabilizes the plaque within the blood vessels. So this is the mechanism in which this biomarker works. So basically there is a cleavage of insulin growth factor from insulin growth 1, and when this cleavage happens within the blood vessels, there is a destabilization of the plaque that happens. So you want to look at the clinical study. This was a clinical study, Merlin Timmy 36. This was a study which came in 2012. They looked at pregnancy associated plasma protein A, and 30-day cardiovascular death and MI was significantly higher in patients who had this biomarker elevated, and 1 year cardiovascular death and MI also was found to be significantly correlative with this biomarker. So this biomarker seems to have good correlation with 30-day cardiovascular death or MI or 1 year cardiovascular death or MI. So another biomarker is membrane attack complex. So this is a myocardium. So the way it works is if someone has had an infarction or an injured myocardium, so that injured myocardium attracts a lot of complement activation near its site. So this interaction of the complement at the site of myocardial injury leads to the production of something called membrane attack complex. It's called MAC, which leads to the myocardial cell necrolysis. So this is the mechanism that we have understood. And this MAC causes the lysis of the myocardium and dysfunction of the myocardium, which becomes irreversible. So we have to look at the clinical study. So this was the clinical study done by the Denmark people. So if you look at cardiology literature, I think there are 3 to 4 countries who have done phenomenal research. I think Netherlands is one, Denmark and USA. I think these guys have put in a lot of work. So this is again from a Danish group. So they looked at 725 STEMI patients and they looked at membrane attack complex, and this also had a good correlation because it had a good correlation with mortality. Hazard ratio was 1.81, and it was good correlation with major adverse cardiac events with a hazard ratio of 1.35, and as you see they were statistically significant. So the French guys looked at interleukin 17 as a biomarker. So if patients with MI had a low interleukin 17, so if someone has had a low interleukin 17, I think it indicated increased risk of death or reinfarction within 2 years, and the hazard ratio was 1.4, and that was statistically significant. And the Japanese guys looked at pentraxin 3 as a biomarker. I think the pentraxin 3 levels, if it was high, it really indicated thin cap vulnerable plaques by optical coherence tomography. So basically if this pentraxin goes up, basically it indicated that your fibrin cap was very weak and it could give way or it could break out or it could cause fissure or rupture of the plaque, which we know leads to thrombus formation. So those are the newer biomarkers. So if you have to ask biomarkers, it is high sensitivity cardiac troponin, it is PPA, pregnancy associated plasma protein, membrane attack complex, interleukin 17 and pentraxin. I think these are the new biomarkers we have. Then we'll move to imaging. So imaging has revolutionized the acute coronary syndrome. So MR angiogram has been found to be really helpful in risk stratification, and they found MR angiogram, if the narrowing is more than 50%, I think it is a good representative of death and acute myocardial infarction or unstable angina in 6.3% as opposed to 0.3% in the control group, and that was statistically significant. So this was study which came from Japan. So MR angiogram could be considered as a screening tool to determine who are the patients who are at risk if there is a narrowing of more than 50%. And then this was a US study which looked at CT angiogram. So this was a meta-analysis of 4 randomized controlled trial of 1,869 patients. They found CT angiogram as a good screening tool which reduces the cost, which reduces the hospital length of stay, and it reduces the patient return within 30 days after a cardiac event. So MR angiogram or CT angiogram is something, CT angiogram is something that is happening in most hospitals in India, at least the big hospitals, as one of the important screening tool. So what are the key elements that people are looking at in CT angiogram? In CT angiogram, they are looking at narrowing of the vessel and attenuation of the vessel lumen and the remodeling index. And they are looking at the volume of the atheromatous plaque. They are looking at angiogenesis in the atheromatous plaque, and they are looking at the lipid core in the atheromatous plaque. So I think these are the key core elements that they are looking in CT. So if you order CT angiogram for any patient, I think these are the things that you need to interpret. And they had an accuracy in detection of ACS, and this again came from US study. And now the US guys have looked at optical coherence tomography as one of the tool to determine the risk of plaque rupture, and it determined plaque rupture in 44% and plaque erosion in 31%, and it identified patients who are at risk at a much younger age by looking at the young patients who have this plaque and who are at a risk of erosion or plaque rupture. And near infrared spectroscopy is being used to detect lipid core, so that is a new modality. And as I said, the Madder et al. Looked at the lipid core assessment. So basically you have an atheromatous plaque, you look at the core lipid, because the area and the volume of the lipid probe will really determine that these are the patients who are at a risk of the plaque rupture or plaque fissure, and that is a good indication that who are the patients who are at risk of developing stem. So we looked at biomarkers and we looked at imaging, MRNG, CT angio, and the newer modalities are new infrared spectroscopy and the core lipid estimation. So we'll move to the therapy part of it. So because we finished your diagnosis, we finished pathophysiology, pathogenesis, we'll move to the treatment aspect. So we'll just talk about what is the latest. So if you look at, as I said, clopidogrel is being de-emphasized. So the newer antiplatelets like ticagrelor or prasugrel are being considered as more better agents. So this was a study which looked at cangrelor versus clopidogrel. Both are reversible P2Y12 inhibitor. This was a champion Phoenix trial. So this was a very big study, close to around 10,000 patients, comparing cangrelor with clopidogrel. As you see, the cardiovascular composite endpoint, which is death and MI, was significantly less in cangrelor group as opposed to the clopidogrel group, and stent thrombosis at 48 hours also was 38% reduction in patients who are on this newer antiplatelets, which is cangrelor, and thus the bar diagrams indicative that superiority of the newer antiplatelets of P2Y12 inhibitor cangrelor vis-a-vis clopidogrel. So the newer antiplatelet seems to have better promise, and that you saw being included in the newer guidelines, that prasugrel and ticagrelor are considered superior to clopidogrel and need to be preferred over that. So this was one study where they looked whether can we look at the platelet function as a tool to determine optimization of the antiplatelet therapy. So this was an Arctic trial which looked in 2,440 patients who had a prior MI and non-ST elevation MI, and this was the percentage of patients. So they looked at the platelet assay to determine whether our antiplatelet therapy is optimal. So they used this verify assay. So, and by using this assay, they increased the antiplatelet therapy to 1/3 of the normal dosage to intensify antiplatelet therapy to see if that created any change in the patient outcome. When they did that, as you see, all the endpoints, cardiovascular, composite endpoint, death, myocardial, stent thrombosis, stroke, major bleed, there was absolutely no difference. So this goes on to show that the conventional antiplatelets, even if you increase the dose, like clopidogrel, you increase the dose and try to do the platelet assay and try to convince yourself, yes, I am giving optimal platelet therapy, but it did not have bearing on the cardiovascular endpoints or the mortality. And the explanations given is because of the possible suboptimal endpoints for platelet reactivity and need for increased potency. That's why we have come to understanding that probably the newer antiplatelets like prasugrel or ticagrelor are more superior, and outcome may not be influenced by only antiplatelet therapy. So the conclusions from this study was routine test for platelet function is not recommended. Basically, the whole understanding is we optimize platelet function by optimizing the dose customized to the patient. We may lead to better outcome, but that failed to show in this Arctic study. So then we look into the dual antiplatelet therapy, whether we should give it for a short duration or a long duration. So this was a landmark study which came from the German group, whether dual antiplatelet therapy should we give it for 12 months or more than 12 months. All right. So this was a meta-analysis of 8,231 patients. This came from the German group. So where there was one group which got extended dual antiplatelets for more than 12 months and the control group got dual antiplatelets less than 12 months. If you look at bleeding risk, there was 2.6-fold increase in the risk of bleeding if you gave dual antiplatelets more than 12 months, and mortality, MI and stroke, there was absolutely no reduction. That's why you see in the new guideline, there is a suggestion that we do not continue to give after 1 year. 1 year definitely we give, but after 1 year you need to exercise the discretion. And even the Twent trial, which was a Dutch trial, they looked at stent thrombosis, whether it had any change, any bearing by not giving antiplatelets for more than 12 months, and it showed the stent thrombosis only 0.3%, which was very negligible and it was not statistically significant. So it goes to show more than 12 months dual antiplatelets may not be needed, and that probably got included in the guidelines as well. So this was another study looking at the potency of ticagrelor, Triton-TIMI trial. So why ticagrelor and prasugrel have scored above clopidogrel is because of this landmark study. So Triton-TIMI trial, this was a US trial. So basically they showed the stent thrombosis reduced by 50% when compared to clopidogrel. This is the Plateau trial, which was a French trial, which showed stent thrombosis reduced to 25% when you compare to the clopidogrel. So these are the two trials which change the paradigm of our understanding of using newer antiplatelet agent. So now we'll speak about triple therapy, because Atlas ACS, this is Atlas trial, so which looked at the triple therapy. So this was a meta-analysis, this came from the US group of 7,817 patients, where they added newer oral anticoagulants rivaroxaban with dual antiplatelet therapy for 5 days, and they compared to the control group. As you see, the cardiovascular composite endpoint, death, MI, stroke, was 19% reduction when you gave triple therapy. So these are high risk patients who had a stent, where you add a newer oral anticoagulant, there was 19% reduction in the composite endpoint, and cardiovascular death, there was 2.5% as opposed to 4.2%. But there was, by adding the triple therapy, there was a risk of major bleeding, but the stent thrombosis, if you see, it was 7% as compared to the 54%, so which was statistically significant. And look at the mortality, there was a significant mortality reduction when you started triple therapy, which is 2 antiplatelet agents with an oral anticoagulant. So what about the aspirin dosage? Because do we believe that 150 mg is needed or 83 mg? Because in India we have 75 mg. So if you see all these trials, this was the biggest study, I think, which makes a conclusive sort of a diagnosis of conclusions. 2,89,333 patients, 136 studies they have evaluated, comparing aspirin more than 160 milligram versus 81 milligram. Clinical outcomes, no difference. And if you give higher aspirin dose of more than 150, there was increased risk of bleeding, 23 out of 1000. And you looked at the Horizon AMI study, if you give aspirin more than 200 milligram, the hazard ratio of bleeding was 2.8, which was very, very high. And recurrent ischemia, there was no difference between high dose and low dose aspirin. And again, the Triumph study again showed there was increased risk of bleeding when aspirin was given at a high dose, and there was increased rehospitalization and reduced quality of life. So basically these are the biggest studies till date we have, which says there is no difference between high dose aspirin versus normal dose or low dose aspirin, which is 81 milligram. So what about the increased bleeding with triple? Because we all can conclude, and which has been included in the newer guidelines, that triple therapy in high risk patients is good enough. So when you give triple therapy, the increased risk of bleeding is definitely there, and that was shown in these studies. So this was the Voice trial, which looked at the bleeding risk. So if you give triple therapy as opposed to clopidogrel with anticoagulant, so they have taken away aspirin in this, so bleeding risk was very high, 44 as opposed to 19.4. But when they looked at the composite endpoints of death, stroke, stent thrombosis, in fact it was lower in clopidogrel plus anticoagulant. So as you see in this particular study, which is by the Dutch group, they saw the underemphasis on aspirin. Here they've used only clopidogrel and anticoagulant with triple therapy. So triple therapy we understand is dangerous, but if you cannot give triple therapy, at least you could consider clopidogrel with anticoagulation as opposed to aspirin and anticoagulation, because clopidogrel with anticoagulation had a better outcome than aspirin with anticoagulation. So that's about the antiplatelets bit. So we understand that the newer antiplatelets, prasugrel, ticagrelor are superior, and in high risk triple therapy is found to be better, but all these therapies to be limited to a shorter duration, which is less than 1 year. More than 1 year, the risk of mortality, bleeding is very high. So we'll come to the triaging bit, invasive management. I think the emphasis is on triaging, taking out the emergency, because triaging, the new emphasis is to happen in the ambulance. From ambulance they come straight to the cath lab, bypassing the emergency department. That is to save, because door to needle time right now the benchmark is around 90 minutes. So it has to be achieved less than 90 minutes, max less than 120 minutes. So primary PCI. So if we do a primary PCI with all this triple therapy, there are two complications that one would expect: reinfarction and bleeding. So there are studies to see which is better, because I'm sure all of you have worked in cardiology. We would have patients who have GI bleed, and we always criticize they put a lot of blood thinners. But this was the study to see which is better. See, what they found is, so you can accept bleeding as a risk, because the bleeding risk normalizes in 1 month, but the recurrent MI, if it happens, if you are compromising on the bleeding aspect and reduce one of your antiplatelets or blood thinners, there is irreversible damage to the heart, because the bleeding risk lasts only for 1 month and there is no irreversible damage. But when you compromise on your blood thinners, there is irreversible damage to the heart. So this was a study looking at the risk benefit balance of bleeding versus reinfarction, and we found we can accept bleeding, but we cannot accept reinfarction, because reinfarction leads to irreversible damage, bleeding leads to reversible damage which we can fix, and the risk lasts only for 1 month, and it doesn't last more than that. And okay, so and this is about stents. I think this is not our area, but just be wary. Now the way to go is drug-eluting stents. So bare metal stents are out, so need for revascularization is less in bare metal stent. So this is just for you to understand. There are a lot of trials that have happened looking at bare metal and drug-eluting stent, and all the studies conclusively show drug-eluting stents are desirable, they are most preferable, and these are all the studies just for your understanding. Examination trial, ZAMI trial, comfortable AMI trial, all different ones looking at sirolimus eluting stent, everolimus eluting stent. This study showed that everolimus eluting stent was found to be superior to sirolimus eluting stent. So basically the gist is drug-eluting stents are the way to go, and I think everolimus scores little better than sirolimus. Yeah. So thrombus aspiration. So that is about stents. So we won't dwell too much about stents because that's not our area. Just couple of slides and we'll be done. Thrombus aspiration. So this was the biggest study which came in 2013, meta-analysis of 18 randomized, looking at aspiration of thrombus versus only angioplasty. They have found if you aspirate the thrombus and then put a stent, the risk of major adverse cardiac events was significantly less and mortality was significantly less. So the way to go is, if there is an opportunity to aspirate the thrombus, it is good to aspirate the thrombus and then do an angioplasty. That has led to the better outcome. And reperfusion injury is what all intensivists see. I think there are newer agents. I think exenatide is something that has been used 15 minutes before angioplasty, and this has shown to reduce your reperfusion injury, reduce the size of infarct, and increase the salvageability of the myocardium, because our whole aim and intent would be to salvage the myocardium and not lead to permanent dysfunction of the myocardium. And intracoronary injection of adenosine, diltiazem and verapamil has also shown to reduce reperfusion injury. And they have used P-selectin infliximab at 20 milligram per kg again to reduce myocardial damage, and they have found good outcome in this Canadian study. So the thrombus aspiration is good, and measures to reduce reperfusion injury by using these agents like exenatide or infliximab are some of the newer things which you can keep in mind. And balloon pump, I think we have understood it is de-emphasized. So these are the two big studies. This was meta-analysis of 6 randomized controlled trials of 1054 patients by the German group. As you see, balloon pump did not lead to reduction in mortality, heart failure or reinfarction. And this was another study, IABP SHOCK 2 trial, which showed 30-day mortality was no difference. So these were the two studies which really changed our understanding of balloon pump, and I think there is a de-emphasis on balloon pump, that it did not lead to any favorable sort of a benefit. But still, my friends, I think most cardiologists still would love to use because of significant hemodynamic changes that we would see in our patient. And this is the last thing about radial artery access versus femoral artery access for angioplasty. I think this is something for us to keep in mind. So very interesting, because these are the 3 studies by US, Italian and Canadian group where they have compared radial artery access versus femoral. And if you see, radial artery access was found to be superior in terms of outcomes. So if you look at the bleeding risk was reduced by 38% if you use radial artery. This was the Rifles TIAC study by the Italian group, where in fact they saw the endpoint, the cardiovascular composite endpoint of death, MI, stroke, revascular was significantly less when radial artery was used for angioplasty. And rival trial, which was by the Canadian group, also showed mortality reduction when radial artery was used vis-a-vis femoral artery for doing your angioplasty. And what they found interestingly was significant reduction in cost by using radial artery. So this is something food for thought for you guys. Keep in mind, radial artery is preferable, and in US around 1/6 of the cases undergo through radial artery. So this is the last slide, lipid and quality of care. So they have looked at lipids, and 6 months post MI, only 33%, only 1/3 of the cases achieve LDL levels less than 70, and more than 100 mg around 33%. So which means post MI lifestyle modification. So this is a quality statement in the newest guidelines where we should really focus on quality improvement after MI, because you put a stent, you do a fantastic job, you put 3 antiplatelets, anticoagulants, all that is good, but if you do not change your lifestyle, it leads to bad outcome. If you have not led to reduction of LDL, if you have not improved your physical activity, see, this is found to be very important. If your physical activity does not improve, rather it decreases by 0.1 meter per second, if there is a slow gait, which means your effort tolerance has come down after an event, it has shown to increase your hazard risk of mortality by 41%. Which means to say cardiac rehabilitation, there is a renewed focus on cardiac rehabilitation. And as you see, this is the quality statement of the post MI, that aspirin has to be taken, aspirin has to be given at discharge, smoking has to be stopped, beta blockers to be given, angiotensin ACE inhibitors to be given, statins to be given. Most important is this, I think in India we may not be following, referral to cardiac rehabilitation, because if they do not improve their effort tolerance, if they do not improve their activity, in fact on the contrary, if there is reduction in activity, 41% increase in the hazard ratio. So take home message, friends, in summary, ACS practice guidelines, the new inclusion is 120 minutes as the timeline for fibrinolytic therapy, angioplasty, percutaneous intervention as soon as possible, dual antiplatelets is the way to go. So aspirin with newer antiplatelets like ticagrelor or prasugrel is preferred over clopidogrel. Triple therapy, high risk patient with a stent who needs to be on newer oral anticoagulants or antiplatelets should be limited to 12 months, because more than 12 months we know the risks are very higher, the risk of bleeding is very high. Understand the pathogenesis is now into 3 arms. There is an obstructive atherosclerosis, non-obstructive atherosclerosis as important pathogenic elements. In obstructive, there is inflammatory and non-inflammatory variables that leads to atherosclerosis. Risk factors, the newer risk factors, oral contraceptive pills, NSAIDs, psoriasis and early discharge. Because I know cardiologists are so overzealous about early discharge, because after discharge at home they have VF or VT, it is a sure death. So there is questions raised about early discharge, especially when you have seen patients with reperfusion injury. Biomarkers, high sensitivity cardiac troponin is here to stay. Pregnancy associated plasma protein A is something that is a newer biomarker. Membrane attack complex, interleukin 70 and pentraxin. So these are the ones which are found promise, but they still need to be incorporated into our clinical armamentarium. So we know drug-eluting stent is superior to bare metal stent. Antiplatelet therapy, I have re-emphasized ticagrelor, prasugrel superior to clopidogrel, and IABP de-emphasized, but I'm sure most hospitals, most cardiologists continue to use that. And most important, put emphasis on cardiac rehabilitation. Any of your dear ones has had an MI, they need to go to cardiac rehabilitation so that their effort tolerance improves. Thank you very much. So hope I have not drained you too much with cardiology.